Afternoon. For those of you who don't know me, my name is Matthew Mutter. I'm down at LSU in New Orleans. And thank you for allowing me to present our position statement for billing and coding for IPPs from a SUP standpoint. I have no disclosures other than the fact that I am not a biller or a coder, but rather just a urologist who is seeking to accurately bill and code procedures and stay in compliance. So why did we create the position paper? Well, as we all know, coding can be confusing. It can be ambiguous. There are many rules, quote unquote, rules to coding that we always hear about and we talk about that we really have no firm backing for, and no one can present any firm backing for justification as to why they do what they do. There's a wide variability among urologists, and you'll see that here in a little bit. And this is also how we get paid for the credit and the hard work that we do. So it's advantageous for us to be as accurate as we can be. Our goal was also to provide a solid foundation on which to guide accurate and uniform coding throughout prosthetic urology. We wanted to establish uniform descriptions and when to code for each procedure. And then, of course, we wanted to make billing and coding less cumbersome, less speculative, and again, more accurate. Our strategy for moving forward is we wanted to identify the most commonly used adjunct procedures during penile implantation, and of course we focused on curvature correction because I think we can agree that that's one of the most common parts of additional procedures during a penile prosthetic. And so what we did was we developed a survey with some basic demographics and surgical scenarios. And we sent this survey out to SUPS members and asked them to code on the case. It was multiple choice format. Again, it was sent to the SUPS members. We sent a total of 99 out. We got 30 responses. Interestingly enough, from our respondents, 15 were in an academic practice, and the remainder were in a private practice. So we had a nice dichotomy of physicians. 73% of these individuals were fellowship trained. And Martin, at risk of overstepping my boundaries here, I dare to say that 12 of these people were high volume at doing 51 to 100, and then 7 performed greater than 100 implants on the year prior. All right, so here's our survey. I won't read all of these questions, but I'll highlight 2 of them. This is the only question that we got uniform answers to, and it was the insertion of a 3-piece inflatable penile prosthesis with an 8-dot plication for dorsal curvature. To me, this makes sense because these are 2 separate procedures with 2 separate CPT codes. So I somewhat expected this. The other question that I'll highlight is our 10th question, which reads, if you're only coding for 1 CPT per procedure, despite doing multiple procedures, why do you only code 1 procedure? And it's, for me, the important answer was that 30% of these individuals fear coding improperly. They didn't want to get into trouble for whatever reason for coding improperly. So it just illustrated the fact that, I think we could probably educate folks on how to properly code and assure them that they're coding in a safe fashion. This is their position paper that we came up. This is currently in press at the Urology Gold Journal. This is my crew that helped me out here. And so these are our statements. And I'll read each one of these and our position statement. So CPT 54235, injection of corpus cavernosum with a pharmacologic agent. So we feel that the vasoactive injection, i.e. lidocaine, marcaine, should go into the corporal body to induce, for an artificial erection per se, to help evaluate for any penile deformities and possibly assist with dilating the corporal for cylinder placement. There are many of us that are probably doing this but not actually coding for it because we're not sure that we should be coding, and so we feel that you can code for this. The other one is 54360, plastic operation to the penis to correct angulation. We feel that this code should be used when the surgeon places either plication, sutures, or performs significant manual modeling. I'd like to focus in on the significant manual modeling. I think it's important that if you do some significant modeling to describe it as such. Or a corporoplasty when there was residual curvature. These are a little bit more straightforward. CPT 54110, excision of a penile plaque or treatment of a lesion. We feel that this code should be used when there is either incision or excision of a plaque without placement grafting material, when there is persistent residual curvature. and then 54111 graft less than 5 centimeters, with the 112 for a graft greater than 5 centimeters. And then finally, CPT 55175, simple scrotoplasty, also known as a ventrophalloplasty. We feel that this code should be used when there is reduction or excision of penoscrotal webbing. And again, this may be something that many of us are doing but not coding for. Our future goals for this are to work closely with billers and coders to ensure accuracy. Ideally, we would be able to keep a central database on each procedure and how it was described, how it was coded, billed, and ultimately reimbursed. And this would allow for better and more accurate tailoring as time progresses. That's all I have. Thank you.